Hey nurses, welcome to the podcast. My name is Kati Kleber. Today we're going to be talking in depth about delirium. So this episode is part of a campaign to help educate nurses about delirium. Delirium research has evolved quite a bit over the years, but practice is pretty slow to catch up. And there are a lot of nurses out there who are very passionate about delirium education because it makes such a difference in patient outcomes and have lots of phenomenal experience, around it. So this episode, we're going to get some definitions. We're going to just talk through maybe a case study, some other interesting tidbits that are going to blow your mind a little bit. And it's to preface the upcoming pod crawl. Don't know if you've heard of a pod crawl before, but basically a bunch of us nursing podcasters are all going to be talking about delirium at the same time. So to check those podcasts out, kind of stay up to date on it, you can go to upmynursinggame.com/podcrawl. I will have a link to that in the description of this episode, and then you can check out the different podcasts that are going to be featured. And I think just having some baseline information will help make those make more sense. And then you can check out some different nursing podcasts. And a quick fresh RN note, y'all. Did you know I've been doing this for 10 years? 10 years. I've been a nurse for 13 years, but I have been doing blogs, podcasts, books, speaking stuff, courses for 10 years, people. So to celebrate, we're going to have a 10-year anniversary sale at Fresh RN. Now, many of you may know I don't do sales very often. We're doing one to celebrate 10 years. Okay, people? So if you go to courses.freshrn.com, you can see the latest course catalog. I just did some updates if you're unaware. So my course Hired is a massive overhaul from my previous course. I made a bunch of updates. It's called Hired, the Ultimate Guide to Mastering Nurse Resumes and Interviews. Oh my gosh, I'm very happy with that product. And then I also recently launched Nursing School Clinical Prep. It's for those of you in school who want to just kind of understand what's going on at clinical before you get there, because it's a little like you can read about it. They don't tell you a lot of things. They tell you the textbook way to do things. We walk through and show you a lot of basic skills. So those are two. I also have all of our specialty courses that are crash courses for anyone new to that specialty, like neuro, ortho, med-surg, ICU, and cardiac. Then I just have my general residency program. And then I also have my professional development ones. So those are charge nurse, preceptor, and critical thinking. All of that, y'all, 30% off. The sale will be, let me make sure I get the right date, April 23rd to 29th. So 1 week. I'm giving you all a little heads up. April 23 through 29. Okay. If you're on my email list, you will get notified. So if you want to not have to remember it, just go to freshrn.com, sign up for my email list. All right, guys, let's dig into delirium. All right, delirium. Let's start with the definition. Okay. So delirium, hospital-acquired delirium, is also known as nosocomial delirium, and it's a form of delirium that develops during a patient's stay in the hospital. It is a sudden onset of confusion, disorientation, fluctuating levels of consciousness. This is often accompanied by agitation or lethargy. In hospital-acquired delirium, symptoms are not present upon admission, but emerge during the course of the hospital stay. Okay? As you can imagine, certain things contribute to the development of it. So let's talk modifiable risk factors and non. So it's kind of like heart disease, kind of like other things, right? Like, what are things about the patient situation that we can change, and what can we not change? The things that we can't change, all right, we can't do anything about it. But the modifiable ones, let's dig into those, because this has massive complications, but implications for us as bedside nurses and the long-term impact to that patient. So non-modifiable, age. Older adults naturally are more susceptible due to age-related changes in the brain and decreased cognitive reserve. Someone who also has pre-existing cognitive impairment or dementia, patients are at higher risk. That's pretty logical. Polypharmacy. The use of multiple meds can increase the risk of delirium, particularly if they have sedative effects. Medical conditions, severe illness, which is if you guys are ICU, your patient's got severe illness, infections, metabolic imbalances, those kind of things can predispose. And then surgery. Post-operative delirium is common, especially in those, again, that are older, who also have pre-existing cognitive impairment. Delirium patient gets a appendectomy, who's 88. There's a very high risk that patient's going to have delirium after surgery, right? Modifiable risk factors, though. That's a big one for us as bedside nurses wanting to prevent it and treat it. So disruption of normal sleep patterns, lack of natural light, lack of mobility, lack of social interactions or familiar faces around them, and sensory deprivation all contribute to the development of delirium. So we really want to dig into addressing the modifiable risk factors and implementing those non-pharmacological interventions like our sleep hygiene, orientation, social interaction. And I want to walk through how big of a deal this can be to patients, because we see them in the ICU and we see them sedated. We think they're resting. They are not. And that everything is fine if they're calm. But we're going to dig into why that might not be the case and what that can do to someone long term, years later after this admission, or even days later. So I want to talk about a powerful case study. All right, let's talk through our case study. Here's a 76-year-old man, history of bipolar and lithium use and alcohol abuse, lives at home with his wife and works as a delivery driver. He had a prolonged period of sobriety and then a relapse and was attempting to withdraw again at home. Oh, just hearing that, this guy's having a hard time. He arrived to the ED already suffering DTs from trying to withdraw at home, and it's unclear when his last drink was. He was combative in the emergency department and was loaded with 16 milligrams of lorazepam. On the floor, he was started on a lorazepam CWA protocol with scheduled diazepam. Y'all are familiar with the CWA protocol. And for those of you who aren't, it is a protocol to routinely assess patients withdrawing from alcohol. You ask a certain amount of questions and it gives you a score. And based on this score, they can get a certain amount of meds to make the withdrawal process easier on the patient and avoid complications. But we're going to hear how that might not always work great. So he was getting that protocol. Over the next 4 days, the doses of it decrease down to 2 milligrams of lorazepam and 10 of diazepam for the day. But then the doses start to creep back up. 5 days later, his doses have increased and he receives 14 milligrams of lorazepam and 15 milligrams of diazepam in a 24-hour period. So this is 9 days after admission. On the medical record, each dose for his lorazepam is charted as for agitation. So here we are, probably at minimum 11 days after his last drink. Do we really think he's still in alcohol withdrawal? Or are we leaving this protocol going because, he came in for that and no one's really thinking or wanting to change that? So what's likely going on here? Is it alcohol withdrawal? Probably not. It's probably benzo-induced delirium with agitation that's being treated with more benzos. For the following 3 days, he remained on that protocol and continued to receive lorazepam and diazepam for agitation. He is too sedated to mobilize and becomes profoundly comatose. On days 11 and 12 after admission, he's on BiPAP for respiratory suppression and altered mental status. The next day, he was intubated. PEEP of 5, 30%, febrile with new leukocytosis, and severely delirious with a RASS of +1. So what do we think happened? He was probably oversedated and weak from 12 days of bed rest, leading to aspiration pneumonia while he was on BiPAP. And he's having delirium. What is the treatment now? Mobility, family at the bedside, sleep hygiene, avoiding medications that can contribute to delirium. So let's talk about this outcome. So care team likely didn't have cultural training to notice this, and he remained sedated and immobilized on Propofol for an additional 6 days. Even after being extubated, he spent an additional 8 days in the ICU with severe delirium and altered mental status and severe ICU-acquired weakness. During his time in ICU, he developed stage 2 ulcers on the bridge of his nose and also on his sacrum. He spent 16 days on the med-surg floor after that, being seen by psych, who insisted in their notes that this was likely severe acute delirium. He developed a Kati and was again treated for sepsis. He finally transferred to a rehab facility, still delirious and unable to walk. He spent a total of 6 weeks in the hospital, had 2 hospital-acquired infections, 2 pressure injuries, and a preventable intubation. He had lots of work. There was lots of work treating delirium, attempting to remobilize him, turning him every 2 hours. He had traumatizing delirium, cognitive impairments, a high risk of not returning home, a high risk of readmission to the hospital with a new acquired infection from his care facility, and even more. So it's not as a bedside nurse, it's not hard to see how that went down. I'm not surprised when I'm reading that. It's a little more heartbreaking because I can see why it happened, how it went down. We just keep going every day and not really questioning things. And this is instead of, oh, wait, he's in DTs, let's get him withdrawn, let's get him through that period and send him home. God was there for 6 weeks. And this will have a lifelong effect on him, likely mentally, emotionally. So I want to talk about some specific statistics related to delirium. These, in the description of this episode, I am going to list out my references for this. So, you can fact check me, people. So, but I'm not going to list the sources here, but I will have them in the notes. So here's some scary statistics. 81% of intubated patients will develop delirium. And is it all really down to having the critical illness itself, or is it because of what we give them, sedatives, when they're intubated? Delirium doubles the risk of dying in the hospital. Doubles it. Triples the risk of dying in 6 months after discharge. And the risks are still high a full year after discharge. For every 1 day of delirium, there is a 10% increased risk of death. Not just confusion happens in delirium, but when you talk to survivors, they tend to report vivid, gruesome, and graphic realities, often far worse than what is happening at the moment in the ICU, that causes deep psychological trauma and is a root cause of post-ICU PTSD. I'm not talking like a little nightmare. I'm talking about you think your kids are being kidnapped. I spoke with Kaylee Dalton, who is very passionate about this issue. I do have an interview with her in a previous podcast episode, but she speaks a lot to survivors, and she has told me various instances of, a patient who thought, how you have your temperature probe and you do check the temperature on the temple and it makes a click. He was sedated on Propofol, and he was having a horrible nightmare that he was in Russian roulette and the person would come put a gun to his forehead and the click was the gun going off around the clock, because they would check the temperature, I don't know, varying levels, but probably often every hour, 2 hours, at least every 4 hours. She's talked about people thinking their children are being kidnapped. What was the other one? Thinking they're being burned alive. Like, they would much rather be awake and uncomfortable with a tube in their mouth than having those horrific nightmares. And they can sense what's going around them, but they can't move their body, and they're terrified. So I think that it's really important to remember that when we're sedating our patients, they're not sleeping. Sedation is not sleep. And we think that they're sleeping because they look rested, but many of them are having terrifying things going on in their brain that is far beyond their control. And we're actively like doing that unintentionally. So I think it's really important to remember how serious it is to put somebody on Propofol, and how we need to turn it off as soon as it's no longer medically necessary. So back to my stats. Delirium is the strongest predictor of length of stay, no matter the diagnosis, severity, or the comorbidities. Isn't that wild? It increases the length of stay in the ICU by almost 5 days and 7 days, almost 7 days, if on the medical floor. Delirium doubles the nursing hours required for care. Let me say that again. Delirium doubles the nursing hours required for care. I think we tend to think the patient who is intubated and sedated is easier because they don't talk back and they're like a lot less physical work. But delirium increases the risk of workplace violence, the removal of lines and tubes. It increases the risk of unplanned extubation by 11 times, increases time on the ventilator, and increases healthcare costs by 39%. Yow. So, and just think, like, let's say you have that patient who got delirious on their Propofol in the ICU, and you finally get them out of the unit and then go to the floor. They are much more likely to come back to you because of a complication on the floor. And because they're at such higher risk for that now, and to come right back to the ICU. So it's part of our due diligence, I think, as nurses to prevent that. And I think, like, I hear the pushback, what else are we supposed to do? Just have them ventilated without anything? Yeah. Have you ever heard of an awake and walking ICU? I have that podcast episode I mentioned from Kaylee Dalton is where she goes in and consults and goes in and teaches people how to create an awake and walking ICU. And that's basically like, if a patient is going to be intubated, you tell the patient, I'm going to give you medicine so that we can put this tube down. But once the tube is down and your vitals look good, I'm waking you back up and we're going to chat. Okay? We're going to get up. We're going to walk around. And that's, you tell people about it. They might forget, but you remind them. And if someone's getting squirrely in bed or getting you get them up, you walk them on the ventilator, you stand them up and get them tired, and then they sleep. And you keep them awake during the day and you let them sleep all night and maintain that good sleep hygiene to prevent those complications. But to implement this into a unit requires quite a bit of culture change and, almost like what happened with central lines and Foley catheters. It used to be everybody got Foley catheters and we all loved it because it was way easier. As a nurse, right? You don't have to get somebody up to go to walk to the bathroom. You have a lot less incontinence. Life is great, right? Well, those cause terrible infections for people. They're not, so much. You have to care for them perfectly. They have to, we all know that there needs to be a really good reason that a patient has a Foley. And I believe the same thing is going to happen with Propofol and intubation. There needs to be a really good reason, like increased ICP, inability to oxygenate while, moving. There's a few things that really do justify that, but it's certainly the exception and not the rule. But I think we're just so used to propofol and intubation, and we say a lot online about how we like our intubated, sedated, restrained patients, which I'll admit, when I was working in the ICU, I was guilty of that. I definitely posted memes of that kind of stuff in the past. And realizing now, when you consider how traumatizing it is to someone to go through that, that's a terrible thing to like make light of. And I do think there's a big culture change that needs to happen to prevent a lot of this very bad complications. So effects do continue after the hospital too. You have post-ICU dementia, which is where delirium survivors actually have a 120 times greater risk of long-term cognitive impairments. And a third of delirium survivors have PTSD. And one of the other podcasts is from A Cup of Nurses. So if you go to that at my nursinggame.com/podcrawl, Cup of Nurses is interviewing a survivor. And I need y'all to listen to it. Because I think we think so much about our work, and we think that I think we do, we all want to take very good care of our patients. And when you're in that ICU setting, you do focus so much on ICU, and it's very difficult to think long-term for these patients, and what it means for them years later, and how some of the things that we've done can impact them. So I think it's helpful to hear that. And for those of you unaware, the ABCDF bundle, so it's this bundle that we dig into another episode that I'm going to drop on the 21st for you to check out. It decreases delirium from 25 to 50%, depending upon the level of compliance. And it's obviously extremely effective. Something like that is really helpful, and it helps us know the intervention. So I talk about that more in another episode, so I won't dig into it here. But it's a tool that we can use. So big picture, the less sedation that is given, the more patients are mobilized, and the more they connect with their families, the less delirium they develop. Maybe we are annoyed with the family, or maybe whatever that might be. But if that family member or various family members are there with that patient who's, on the brink of confusion, and then they hear familiar voices, see familiar faces, that can bring people down from that brink and provide that comfort and ultimately make your job easier. I mean, if we want to look at it from that perspective of how does this help me, which I don't think is really part of nursing or not why we do it, right? But if you want to look at it from that perspective, that provides such therapeutic support to the patient. So I think that those are important things to keep in mind. So those are some statistics that I think are really important for us to be aware of. So I want to talk about some cross-department considerations, because, it's not like a patient comes into the ICU and just stays there and doesn't go anywhere else. Patients are passed from one department to the other, and their delirium and risk for delirium obviously follows them. So let's say a patient came into the ED and they got bolused with benzos. That will create kind of this mess of agitation, delirium, and coma, possibly. Or I don't want to say coma. I don't love that word. But altered level of consciousness for the floor of the ICU to deal with. They get this medication down in the ED and leads to confusion. Now they're in a completely different place with completely different people and no one familiar there. I mean, that's just going to increase the confusion. And we usually continue that pattern of responding to emergent agitation with more Ativan. It locks and loads the patient into this roller coaster ride of delirium, and we bolus these benzos and all the sequela that follows. In ICU, the sedation, it can be a mess of delirium and weakness that can set our floors or step downs or maybe inpatient rehab for continuous turning and increased fall risk, line removal or tube removal, agitation. and even prolonged stays. With the floor that's sedating with like Ativan or antipsychotics, that naturally impedes their mobility, causes that delirium, which oversedates and leads to intubation, like our case study. And that's another prolonged stay that can, like that patient had, increased risk for infections and sepsis and whatnot, and longer stay. The ICU sedates and like immobilizes the patient. They extubates them. They send them to the floor. They're weak with poor secretion clearance, airway protection and diaphragm dysfunction. So they're at high risk for aspiration or inadequate like ventilation for themselves. So they might be still struggling with hyperactive or hypoactive delirium and are difficult to manage, and they end up receiving more sedatives on the floor. So, they're laborious and dangerous to mobilize, and they continue to be in bed. Then it's not surprising when they develop things like pneumonia, pressure injuries, CAUTIs, CLABSIs, and get back to the ICU. So bringing it back to the ABCDEF bundle, that actually decreases the risk of readmission to the ICU by 46%. And that's mainly because it prevents the delirium. And I think this is this elephant in the room, or I don't even know if it's an elephant, because I don't think we realize it's in the room. I think we see these problems in isolation and we want to help, and they're agitated. I know what helps agitation is this medication, so I'm going to give it, and that's what I'm supposed to do. When it's kind of it's like we need to kind of step back and look at the full picture of all of our interventions, or not doing some like sleep hygiene, not trying to keep patients awake during the day, and making sure they sleep at night, making sure there's family members there, making sure they're getting up and moving around and they're not missing physical therapy. I mean, they better be coding if they're not missing physical therapy kind of thing. So I think we don't put all of those pieces together. So I think that's really important to like step back and put all those pieces, put all those pieces together. So I want to briefly talk about kind of how we as a culture of nurses really view delirium. And unfortunately, I think our secondary trauma from caring for critically ill patients comes into how we view it, because a lot of us have kind of a dark sense of humor, but that is a symptom kind of vicarious trauma, because we lose touch with the humanity of some of the things that we're doing, because joking about it is a way for us to cope with it. But unfortunately, that's not a mature, balanced way to cope. Like if we have to cope with the reality of our job by dehumanizing the people we care for, it's not an effective coping mechanism. And I think it is under our responsibility as professional nurses to care for ourselves in a way where we are not resulting to mocking the terrifying experience of our patients, to bond with each other with like laughing and gossip and connection with, oh, only you would understand because you've been through it too. We can do that without it being at the expense of others, which is why now, as a nurse who's been a nurse for 13 years, when I see those memes, like there's this one I'm thinking of specifically, it's like this mom on a computer, and on the floor behind her are her 3 kids all tied up and with a gag on their mouth. And it's joking, like the mom, that's how she can work, is by doing that. Like the kids are smiling and it's not real. But the meme is what's next to the mom says ICU nurse, and what's next to the kids says intubated, sedated, restrained ICU patients. And I just imagine if I was that patient in the ICU who was having vivid visual hallucinations that my children were being kidnapped and I was physically tied down and I was stuck in this alternative reality for 5 days. And then I get online and I see nurses sharing that kind of stuff. I can't even, ooh, that makes me want to cry. I can't even, that's just so, I don't even know the words to say how insensitive that is. And I think it's like one of those, whoa, not only do I need to change my physical practice of what I'm doing, but I need some help processing what, how I'm coping with this. There's that book that I always recommend. I'll put a link to it in the description of this video, that, trauma stewardship book from Laura Vanderlipsky or something. It's a blue cover. I love that. I wish I had it with me right now, but I don't. It's actually on my nightstand because I was reading it again and half of it's highlighted. And one of the signs of trauma exposure is this, like making light and fun of things that are actually quite cruel. So I think that it's not just us like privately saying things to each other, which I don't think is the best, like about that, but it's public. Like patients can see that, people can see that stuff. And it really dehumanizes our perspective and relationship with patients. There's like no expectation to allow them to communicate, be autonomous, move, or even walk out of the ICU. It's like we're mad at them for needing care and putting us through the trauma when, while there are people out there who make decisions that land them in the ICU, the vast majority are not there for that. Even then, it's not our job to judge. I think that it reflects that we really need some trauma-focused therapy, I think, if we're really putting that kind of stuff up and making light of it. And I think, so Kaylee Dalton, again, she had this great quote that I wanted to share word for word. She said, "Why in 2023 are hundreds of thousands of people laughing about the loss of human connection, communication, dignity, autonomy, identity, career, relationships, quality and quantity of life? Why don't we understand that we are joking about torturing vulnerable human beings that have entrusted their lives and loved ones in our care?" And I don't think I could say it better than that. That's why I wanted to read it word for word. And I think that it's like we've got some misinformation that impedes our evidence-based practices and continues to like disconnect between what we see at the bedside and the patient experience. And then a lot of it, if you're working in the ICU, you're exposed to vicarious trauma, secondary trauma. You're not having the trauma happen to you, but you are watching it and therefore it impacts you. And I think that if it is appropriately dealt with, you would not find those things funny. Like, I was numb working in the ICU emotionally because that's how I coped with being there. And since I've had quite a bit of like therapy and processing those experiences, and now I don't find any of this stuff funny. I see people put these memes up, I unfollow immediately because it's disgusting to me, to be honest. They're sickening to see that because I've come back in touch with the humanity because I don't need to be in that numb place to function. And I think there's a way to do that, which is why that book exists, to enable you to be present with someone's pain but not over identify with it and be able to like walk that line and do that self-care so that you don't get to that jaded, like that. Becoming a jaded nurse is not a badge of honor and it's not at all where you want to be. I do think that we can romanticize that, but it's a jaded nurse is that way because pain and suffering. And I don't think that that's something we should strive for. And it's really important, I think, for us to note that our influences and beliefs about sedation really play a role in the decision making that drastically impacts the human beings, real human beings that we're caring for. So I'll get off my soapbox with that one, but I think it could not be more important to kind of meditate on that a little bit. All right, let's talk fast facts. I got a whole bunch of fast facts. All right, I'm going to just read through them. These are so important. So nursing is an evidence-based discipline. But is evidence really guiding our sedation practices? Early deep sedation is an evidence-based predictor for mortality. For every 1 milligram of Ativan, there's a 20% increased risk of delirium. For every 1 milligram of Versed, there's a 7 to 8% increased risk of delirium. So if you're giving 5 milligrams an hour times 24 hours, you're significantly increasing their risk. Benzos increase mortality. And I said this earlier, sedation is not sleep. Propofol and benzos disrupt brain activity and it prevents the REM cycle. We're causing lethal and inhumane sleep deprivation. Gonna say that one more time. Sedation is not sleep. Propofol and benzos disrupt brain activity and prevent REM cycle, which is lethal and inhumane amounts of sleep deprivation. And mechanical ventilation is not an automatic indicator for sedation. Just because someone's ventilated doesn't mean they need to be sedated, because continuous sedation comes with high risk. Patients are already vulnerable and at high risk for delirium, so we don't want to destine them to have delirium when we have proven tools to avoid this lethal, damaging, and dare I say torturous condition. Continuous and especially deep sedation is essential in a few situations. Increased ICP, serious neurological trauma or issues like status epilepticus. That's a big one where you're going to be throwing everything at them and to get that seizure activity to stop. And that is definitely taking precedence. But maybe someone who even has the inability to oxygenate with movement, that would be the severest ARDS patient or cardiogenic shock. Like those very specific situations, it makes sense to have continuous deep sedation. But that's only a few things. There's a lot of things that we don't need to sedate for. And are we continuing to run vasopressors to compensate for the hypotension that comes with sedation that's usually unwarranted? That's a thing to think about too. I know if I got propofol, my blood pressure would tank. Would you need to put on some Neo to increase my blood pressure or give me some fluids and then Neo or Levo or whatever it is? There isn't any evidence to support increasing the risk of ICU weakness with vasopressors solely to support the use of sedation. And y'all know when people have those vasopressors are so high risk for things, tissue necrosis, like serious conditions that are life altering. The ABCDF bundle is not just a checklist to require more charting and starting and stopping sedation. The goal is to produce patients who are more awake, cognitively engaged, physically active, which ultimately serves to facilitate patient autonomy and the ability to express unmet physical, emotional, and spiritual needs. So is that what we want? Do we want our patients to be able to be awake, let us know what they need when they're scared, when they're hesitant, when they're like needing your support? Or do we want to just have comatose, unresponsive, and immobile people that we care for? There is something, the PADIS guidelines, pain, agitation, delirium, immobility, and sleep disruption, is automatically starting our sedatives and opioids on every patient, really practicing those guidelines. Pain is best assessed when patients can report it. Agitation is best addressed when we can assess the root cause of it and prevent delirium. delirium is best prevented when we can avoid the I'm going to say it wrong, deliriogenic medications that aren't needed. Immobility is inevitable when we automatically sedate people. It makes sense. Sleep is disrupted whenever sedation is given. So it's really important to consider that just because they're laying there they're not asleep. They're not getting any REM cycle, which is the restorative real sleep. They're not ever getting there. And so it's important to remember that, I think. Okay, let's talk about those awakening and spontaneous breathing trials, sedation vacations, because I think what those can easily turn into is just something to briefly wake someone up in the morning and then put them back down. So it's important to ask what the objective is of the awakening trial. Are we just taking a quick break and making sure they didn't have a massive stroke? Or are we really assessing for the resolution of indications for sedation? With the goal of actually turning it off. Are we supported and taught appropriately how to perform a successful one? Do we respond with connection, communication, addressing pain, family involvement? Are we using occupational therapy for cognitive integration and mobility, and physical therapy for mobility? And if we continue to deeply sedate in response to agitation, then we end up with patients that are sedated because they're intubated and intubated because they're sedated. So this increases your workflow, halts your bed flow, increases all those complications like your VAP, Kati, Kati, which all create a worse experience, is probably the best word, for patients, families, and even staff. And are we only doing those sedation vacations to quickly, just do this quick check once ventilator settings are minimal? What is the evidence to support that? Why do ventilator settings guide our sedation practice? Is not evidence to support that cultural training. The main reason for a failed sedation vacation is often agitation, but are we addressing the cause of agitation, or are we masking it by resuming the sedation? How do we know if they're scared, in pain, lost in alternative realities, need to have a bowel movement, need to communicate, if we run back to that deep sedation? Can you imagine being confused, thinking you're someplace you're not? You don't know where your family is. Maybe you've even forgotten who your family is. That much of a detachment from reality, and you have to have a bowel movement, and you don't know where you are, and you're strapped to a bed. And we're woken up for a moment, and then we were really agitated, so we put them back down. So a top cause of agitation is delirium. Does it make sense to respond to delirium with medications that likely make it worse? I don't think it is. And is a 5 a.m. awakening trial really appropriate? It's a nurse in a dark room, maybe with respiratory therapy, busy and exhausted at the end of their shift. And is that really the best time to do that? Or should we do it when there's sunlight, when we can open the windows, when maybe a family member is at the bedside, multiple, you as the staff member, maybe with respiratory therapy, and you're there together to truly assess? So that does bring me to talking more about the impact of family involvement. So like I said, the family makes a big difference. And the F in the ABCDEF bundle is for family engagement. This is a crazy statistic. I saved it for now because I wanted to talk about it with the family stuff. Family involvement decreases rates of delirium by 88%. 88%. We don't have a pill, ladies and gentlemen, that will decrease delirium by 88%. But you get Mima's husband or daughter or whatever at the bedside, and they're hearing that familiar voice, feeling that hand on their hand. That regular family presence can decrease the rates of delirium by 88%. What? I think that was that statistic was just jaw-dropping to me. When we have patients who are doing incredibly poorly and have terrible outcomes because of delirium, and then a family member can make that big of a difference, Hello. Like, I will take dealing with the frustratingly annoying family member if we're going to have significantly improved outcomes from them simply being at the bedside. Um, simply put, if we're not involving families, we're not practicing evidence-based medicine. Family visitation in the ICU is associated with lower psychiatric disorders following discharge, and there's no evidence to support visitation restrictions. But evidence does prove that liberal visitation decreases trauma, anxiety, and better outcomes overall. Visitation restrictions, like as only certain hours or very limited number of visits, are kind of archaic and have proven to have worse outcomes for the patient. And nursing can play a role in the development of visitation policies. And do we really understand the role of families in keeping patients safe from delirium? And do we know how to utilize them in treating delirium and helping with mobility and keeping patients safe? Now, I know not all families are created equal, and there are some jerks out there. Definitely dealt with them. I'm sure it hasn't gotten better over the last few years. But to deny all patients in your unit access to their family during the worst time in their life, I think is inhumane. And those who are unsafe or not okay family members, we can leverage things like security to deal with them appropriately. I get it. I've been there where I'm like, oh, it's so much easier when I don't have visitors here. But not having visitors there makes the job at the bedside harder. So, okay, we take away visitors and our family members or our patients end up doing much worse. That's not a fair trade-off in my brain. Like, I mean, at the end of the day, while I want my job to be like as smooth as possible, I don't want to make it so smooth that I ensure my patient has worse outcomes because of it. So I think that's an important thing to consider, and that, some families are not cool and really frustrating and really annoying. But that's not like justification for denying patients that. And we can leverage our resources to ensure that we're safe at the bedside, and that, we have security and other means of dealing with those who do get out of hand and are not appropriate. And those visitors don't need to be there. But the ones who are helpful and caring and are not going to hurt anybody definitely can be. So let me cap this off with my take-home messages. Number one, if you don't remember anything from this episode, I want you to remember sedation is not sleep. They could be locked in a horrible nightmare, and we're keeping them there. Sedation is not sleep. They're not well rested when they've had 3 days of propofol. It's not like you slept for 3 days. No, their brain was still active. Their eyes were closed. There needs to be serious justification for the continued use of deep sedation. That means ICH, seizures, like status level of seizures, not intermittent seizures. Ability to oxygenate with movement, or inability, to oxygenate with movement. Those are your exceptions. Getting patients out of bed while ventilated is evidence-based practice. Getting patients out of bed increases your workload at the time and actually decreases, the level of sedation and confusion. So if we want to be completely like self-centered about this and just look at it through the lens of workload, this actually lowers the workload. Another big take home is family engagement reduces our delirium by as much as 88%, our rates by 88%. And I want you to consider how you'd feel if you were intubated and sedated for a week in an ICU and saw on social media nurses laughing and joking about how they loved restrained, intubated, and sedated patients. Or if that was your mom or your daughter or your friend or whomever, and that's what you saw. And I want you to consider that before choosing to post those things. I know it is a free country and you can make those choices, but I think our choices have consequences, positive or negative. And I think that while you might be connecting and laughing with a nurse and it might feel good in the moment, it is not a mature coping mechanism for the very real trauma you experience as a bedside nurse. And it definitely has an impact on the people who view it. At the bedside, I want focus on modifiable risk factors. We can't change that they're old. We can't change that they just had a surgery. We can't change that they have dementia at baseline. But we can focus on sleep hygiene. We can ensure that they have a quiet, comfortable place to sleep. And we're trying to keep them awake during the day and have the curtains open. And then at night, we're allowing their brain to transition to sleep. We're closing the drapes. We're keeping the lights as low as we can to safely do our job. And we're clustering care as much as possible to allow the longest amount of time for that person to sleep. We focusing, that is such a big thing that us at the bedside can do. Also, orientation. That means providing clear signage and clocks in the patient's room. Like literally, we have the whiteboard, and having the date written on the whiteboard, the day of the week, that helps with their orientation status is big, and where they can see it, and having the clock in their eyesight, and maintaining or frequently letting them know, reminding them who you are, where they are, what's going on in the world today. Like, I don't know if there's, maybe it's March Madness or whatever might be going on in the world or might be important to that person. Making sure to, bring that stuff up. It can help. You're on the brink of confusion, then someone reminds you, oh, wait, yeah, I'm in the hospital. This is my nurse. It's Saturday the 24th. Like, I've been here for 3 days. Oh, okay. Like pulling those pieces back together. Sometimes patients just need a little nudge with that. Social interaction. So we want to encourage family members and friends to visit and engage with the patient. Familiar faces provide reassurance, promote a sense of connection, and those social activities can maintain that cognitive function and reduce feelings of isolation. Promoting that mobility and the physical activity. So we want to encourage them to move around and engage in light physical activity as they are as tolerable, to maintain that mobility and strength. And we want to reduce the risks of anything like complications associated with things like bed rest, prolonged, like blood clots, pressure ulcers, that kind of thing. And y'all, I know it's like physical therapy, they'll come and they'll check with you to make sure it's okay to work with a patient. That patient better be working with physical therapy, even if it's just standing at the side of the bed, doing a few movements, whatever it might be. Like, actively coding patient won't work with physical therapy, but patient had a hypotensive issue and now they got a bolus and they're awake and doing fine. They need to be working with physical therapy. They need to be getting up probably. You know what I mean? Like, that's not a justification to miss physical therapy because of the profound benefit that has. And then that helps with decreasing agitation and also helps with them sleeping better. Win-win. They need to do physical work that is challenging. It's good for their brain. It's good for their body. It's good for you. It's good for everybody. So they need to engage with that. And there needs to be a really good reason before they'll skip out on that. A structured daily routine is also really important. Consistency as much as we can with meal times, therapy, rest period. Like, if you come in as the day shift nurse, hey, I see we're going to do a CT scan this morning. Okay. And then we're going to have lunch. I'm going to get you up in the chair. You're getting up in the chair. I know you don't. I know you like to eat in bed, but you're getting up in the chair. Physical therapy is coming by this afternoon. They're going to take you on a long walk. They're going to work your butt, and you're going to take a little nap, a short nap. I'm not letting you sleep too long. Then you're going to get up and you're going to sit in the chair for dinner. Okay. Then you're going to watch your favorite show that comes on at 6 p.m. And then we're going to go on one more walk, and then you're going to bed. That kind of thing. So they can have that structure. So I think those are the take-home points that we really need to focus in on for our patients to help improve their outcomes and improve our workload at the same time. So for my next episode, I do have an interview with a rapid response nurse about delirium. It is Sarah from the Rapid Response RN podcast. It's a great podcast. Please check it out. She's got tons of great episodes. We're going to discuss a powerful experience that she had as an ICU nurse dealing with delirium, common mistakes new nurses make regarding delirium, and little tidbits about nurses who are new to working with rapid response teams, because now today she works as a rapid response nurse and she is a wealth of knowledge. So that about does it for delirium. Remember that this episode is part of that campaign to help educate about delirium, and they will drop, some episodes will drop. So I want you to go to upmynursinggame.com/podcrawl to learn about all of the different episodes coming out, specifically the one I really want you, if you don't listen to any of them, I want you to listen to the patient interview. Pretty profound. So I wanted to make sure you go to freshrn.com as well. Get on my email list. You can stay up to date on my my sale that is coming up. 30% off, y'all. Really haven't had a sale in years. Thought my 10-year anniversary would probably be a good idea. I mentioned earlier that we updated Hired, the course. We added a ton of features and videos, including a 3-page master list of nursing job options, some of which I'm sure you had never considered. Answers to burning questions like how to navigate it when they ask you what your desired pay is or what's illegal for them to ask you. And I added a question and answer database where I dig into the most common interview questions and walk you through what they're assessing by asking that question and how to craft your authentic response. I even have word-for-word scripts for things like how to write a follow-up email, a really good one, and even some negotiation tips. So if you want to check out that one specifically, you can go to freshrn.com/hired, HIRED, and that's where you can check out that course specifically. If you want to look at all of them, you can just head to freshrn.com, click courses, and check out the latest course catalog. So thanks again, nurses, and stay fresh.